I have the pleasure of introducing our next speaker, Dr. Nielsen Fernandez-Becker, who, I thought I knew pretty well, but then the CV is has so much more. So she graduated from, she did her MD PhD at the Albert Einstein College of Medicine in New York and did her training at MGH and Beth Israel in Boston before coming to Stanford, where she's been with us since 2009 and is currently clinical associate professor. She specializes in esophageal disorders, GI motility disorders, and celiac disease. She's the director of the Stanford Celiac Program and a member of the Stanford Esophageal Center. I spent many afternoons, mornings in her EOE clinic as a fellow, and I heard there have been updates since then, so I am looking forward to your talk.
Thank you so much for the invitation. It's so nice to be here in person. Okay, so EOE is a clinical pathologic disease. So not only do we need to have esophageal eosinophilia, there also has to be symptoms and signs of esophageal dysfunction. The diagnostic criteria includes symptoms of esophageal dysfunction, evidence of eosinophilic inflammation, defined by more than 15 eosinophils per high-power field, and exclusion of other causes. This is a list of what other causes may be. The number one entity being GERD. Now, last year, the AGA guidelines were updated, and response to PPI is no longer a diagnostic criterion. And we'll talk about the path that got us there and why this is relevant. Now, let's talk a little bit about the pathophysiology. So EOE is a disease that's antigen-driven. And basically, ingested antigens cause an allergic and inflammatory reaction in the esophagus. And this leads to inflammation that causes dysmotility, as well as structural changes through fibrosis that will then lead to food impaction and dysphagia and other symptoms. Now, when you look at what's happening at the molecular level, there's several factors at play. So definitely the barrier function is impairment of the barrier function is one of the causes. And what you have is a food antigen is eliciting a Th2-mediated T-cell response that then leads to production of cytokines that are important for eosinophil mast cell development and maturation, secretion of substances like TGF-beta that leads to fibrosis and dysmotility, as well as factors that will further impair the barrier. And one of the things I will touch upon is that a lot of these cytokines are therapeutic targets for novel therapies for EOE. It's interesting that the presentation of EOE differs with respect to age. Children present with more protein symptoms like failure to thrive, nausea, vomiting, picky eating, whereas adults tend to present more with dysphagia and symptoms associated with dysphagia. Heartburn and chest pain can also occur, but they tend to be a little bit atypical. Now, part of the reason for this is thought to be due to what we think the natural history of EOE is. Normally, the esophagus is very thin-walled. However, in EOE, as inflammation ensues over time, the inflammation leads to fibrosis and luminal narrowing that could be focal or diffuse. And the hope is that if we intervene early on, then we could prevent these complications. Children tend to present more earlier in the inflammatory phase, whereas adults are thought to present more in the fibrostenotic phase. Now, clearly, this is not the entire picture. We have children who present very early with strictures. And when people have looked at gene expression in esophageal biopsies of patients with and without food impaction, the gene expression profile is very different. So clearly there are molecular phenotypes, and the hope is that in the future, if we understand this better and we understand the clinical course, then maybe we are positioned better to intervene to prevent problems down the line. With regards to epidemiology, this is an atopic disorder, and like other atopic disorders, it's male predominant with 3-to-1 ratio. It is currently the most common cause of food impaction, and it has an estimated prevalence of 0.5 to 1 per 1,000. And it is a frequent cause of dysphagia in patients undergoing endoscopy for dysphagia. Over the last few decades, there's been an increase in incidence in many parts of the world. And this is not thought to be purely a better recognition of the disease. However, the factors that are driving this are still not very well understood. No EOE lecture is complete without a historic perspective, and this is mine. So the first case of EOE was published in 1977. But it wasn't recognized as a distinct entity until the mid-90s. And the first clinical guidelines didn't come out until 2007. And that's when we developed a diagnostic framework for diagnosing and treating the disease. The concept of PPI-responsive eosinophilia was introduced in 2011. And at that point, basically, PPI response became part of the definition of EOE. We only called it EOE if the eosinophilia persisted after an 8-week PPI trial. Now, in the years that followed, a lot of research was done, and it was recognized that PPI-responsive eosinophilia and EOE were actually identical with respect to clinical characteristics, histologic, and molecular factors. Sorry, can I have that slide back a little? And this, recognizing that PPI-responsive eosinophilia and EOE are essentially the same disease, PPI response was removed as a diagnostic criteria in recent guidelines. Now, to make the diagnosis, we rely on taking biopsies, and we recommend taking biopsies both in the distal and the proximal esophagus. And the higher the number of biopsy, the higher the diagnostic yield. 6 to 9 biopsy has a sensitivity of close to 100%. And endoscopically, there are some factors, some features that are very typical of EOE. And these could be described using an endoscopic, EOE endoscopic reference score, or called EREFS, which stands for edema, rings, exudate, furrows, and strictures, and these could be graded depending on severity. Normally, the esophagus is very thin wall, and you should be able to see the blood vessels through. However, with active EOE, you lose the ability to see those blood vessels because of edema. And there's also vertical grooves that we call furrows. These are edema, furrows, and also these white exudate patches that represent eosinophilic abscesses are markers of inflammation. And we recommend targeting those features to maximize the diagnostic yield. There could also be rings that are more fibrostenotic and manifestations, as well as strictures. And of course, there's one of the consequences is food impaction. Patients with advanced fibrostenotic disease often have narrow caliber esophagus, where the esophagus is diffusely narrowed. Other features include crepe paper esophagus, which causes its mucosal fragility, and what we call the tug sign, which is resistance that you encounter when taking a biopsy. Now, the hallmark of EOE is eosinophilia. However, there are other histologic features that could be important for disease severity and esophageal remodeling that we haven't really accounted for in clinical practice. And this includes basal cell hyperplasia, which you could see here by the bar, dilated intracellular spaces, lamina propria fibrosis, clusters of eosinophils that we call eosinophilic abscesses, and eosinophil surface layering. Now, there has been a quantitative study that has been a quantitative score that was designed for the purposes of following outcomes in clinical trials. It seems to be very responsive to treatment and correlates really well to response. However, we don't know where that's going to fit in clinical practice, but that is under investigation. So in terms of goals of treatment, our primary goal will be to improve symptoms, and this includes trying to induce a histologic remission, improving esophageal function, and maintaining the lumen patent. So with regards to treatment, there are three broad categories: drugs, diet, and dilation, the 3Ds. Two of these, drugs and diet, target inflammation in the esophagus, whereas dilation is the tool that we use to treat the fibrostenotic complications of EOE. With regards to PPIs, there's been a lot of observational studies and meta-analyses that are shown here that have estimated the efficacy of PPIs from anywhere from 30 to 50%. However, so it might be a surprise that the latest AGA guidelines gives it a conditional recommendation. And the reason for that is that the quality of the studies was very variable. They varied with respect to patient selection, dosing, duration of treatment, and study design and definition of response. So it was very difficult to really compare. And thus, that's why it's a conditional recommendation. That's not to say that these are not valuable tools to treat in clinical practice, and they're still considered a reasonable first-line therapy for certain patients. The mechanism of action of PPIs and EOE is not thought to be due to acid suppression. Instead, it seems to act in the eosinophil pathway. And in vitro, they've shown that treating biopsies of patients with EOE that are responsive to PPIs, eotaxin, IL-13, and IL-5 decrease after treatment the same way that steroids induce this kind of response. So moving on to topical steroids, which is the other drug that we use these days. The top row is basically what we have available right now. We have fluticasone inhaler, which is what we tell patients, squirt in the back of your mouth and swallow. It is designed to be inhaled. There's also fluticasone discus, where we could tell the patients to take it apart and to swallow the fluticasone powder. And then there's budesonide. Pulmicort respules is probably the most common, and we have patients mix it with Splenda or honey to increase the viscosity and the esophageal contact time. However, there are other formulations in production that are not yet available, but hopefully will be soon. There's a budesonide oral suspension and fluticasone oral dispersible tablet that have shown very good efficacy in phase 3 trials. And in Europe, budesonide effervescent tablet has already been approved. And hopefully we'll catch up with those soon. Now, topical steroids are very effective, and this has been shown by many studies. And in the technical review, the AGA technical review last year, they looked at 8 studies encompassing 437 patients. And over 70% of the patients had a response compared to less than 15% with placebo. And while these are highly efficacious, if you stop therapy, there's a very high rate of recurrence. So the argument is often made for maintenance therapy. And right now, maintenance therapy it's a case by case. There is mounting evidence that it's safe, but there's still a lot of unknowns. So on the pro side is that it's highly effective, and we think that it may decrease the need for dilation, but that's yet to be definitively proven. However, it is costly. There are no FDA-approved medications so far, And the truth is that we don't even know what the right dose is and which are precisely the patients that would benefit from this. And per new age, the new guidelines, it is a conditional recommendation. It's something that is based on the clinical course of the disease. Are more likely to recommend maintenance therapy in somebody who's had many food impactions and who has narrow caliber esophagus than someone who has a mild disease. Now, there are promising biologic therapies. So this is another rendition of the pathophysiology. And this is to show you that there's a lot of molecular targets that are being investigated, including blockade of anti-IL-4, anti-IL-13, and some molecules like Siglec-8 that are present on eosinophils and trafficking. Probably, and this table is just telling you of where we are with respect to those. Probably the ones that are further along in the pipeline are dupilumab that blocks anti-IL-4 and 13, and RCP 4046, which is a monoclonal antibody that blocks anti-IL-13. And these are currently in phase 3 trials. With regards to diet, there are 3 major categories that have been examined. And those include elemental diet, which essentially is feeding the patient amino acids, and reintroducing food slowly. It's very labor intensive and takes a very long time and many endoscopies. It is the most efficacious, but because of its drawbacks, it's not commonly implemented. The most common dietary strategy are what we call empiric, which are the most common is 6-food elimination diet, but there's a 4-food elimination diet, 2-food elimination diet, and what we call the 2-4-6 step-up elimination diet that we'll talk about in a second. Also requires multiple triggers. It has less efficacy than the elemental diet, so that's a drawback. And finally, there's the allergy testing directed diets, which are surprisingly have less efficacy, but it seems attractive because you would think that if you could identify the food, then you could reliably remove them. But it turns out that probably it's not just IgE-mediated antibodies are important here. It seems like IgG4 also plays a role, and that may account for this. So let's go over some of the algorithms that we use. So there is the step-down approach, where you would start with a 6-food elimination diet or 4-food elimination diet. And the foods that we eliminate are seafood, nuts, soy, egg, meat, milk, and gluten. Now, nuts gets a little tricky because some studies say omit 3 nuts, others peanuts. So sometimes this diet actually becomes an 8-food elimination diet. But the idea is that after eliminating all of these, an endoscopy is done. If the eosinophilia is treated, then you introduce 1 item every 6 weeks or so. And we recommend repeating an endoscopy after 2 items are introduced. And if there is if there is recurrence of the eosinophilia, then there's a 6-week washout before resuming reintroduction. So as you can see, this could take a very long time, and on average, it takes about 9 endoscopies and over a year. How the order to introduce the antigens it is variable with respect to patients, because patient experience to different foods is important here. But statistically, the foods that are more likely to cause a reaction are dairy and gluten. So those usually are reserved to be introduced at the end. The other approach is what we call a step-up approach, where you start, this is less restrictive, so patients might be more interested in it. You start with omitting the 2 most common antigens, and then the diet becomes more restrictive if the eosinophilia persists. Again, it does require multiple endoscopies. Now, the dilation is used to treat eosinophilic fibrostenotic complications as opposed to inflammation. And initial guidelines recommended against doing dilations because the thought was that the risk was very high for perforation, but it turns out that in the last decade, we have learned how to do these safely. Both balloon and savories are used, and the complication rate is very similar. In the AGA technical review, the perforation rate was actually 0.4, a lot less than was initially reported. The goal of therapy is to increase the lumen to a minimum of above 15, because that's when we think patients have to modify food. Possible complications have to be related to the patient or the risk of perforation and severe chest pain that tend to occur. We recommend adhering to Joe Richter's recommendation of start low, go slow, and reassessing after very small increments. And you have to be prepared for the dramatic look of these dilations. This patient actually developed pretty severe chest pain for which we treated with medication, but he did very well. And this is what an effective dilation may look like. Sometimes we can't really see subtle strictures, and in fact, endoscopy could miss strictures that are greater than 13 millimeters. Sometimes complementary tests like esophagram and Endoflip, for those of you who aren't familiar with Endoflip, it's a catheter, a floppy balloon that it's filled with a conductive fluid. There's 16 impedance planimetry sensors in the core, and we apply a current to it. And what it can do, it could give us a 3D rendition of the esophagus. We use it mostly to look at the distensibility at the EGJ for evaluation of dysphagia and also for achalasia, but it can be used in eosinophilic esophagitis to look at the wall stiffness, and it could help us identify subtle strictures. In a normal person where the distensibility of the wall is normal, increasing the volume in the catheter results in increase in cross-sectional area that's proportional to the pressure in the bag. However, in EOE, where the lumen is narrow and stiff, what will happen is as we increase the volume, the intra-bag pressure increases, but the cross-sectional area plateaus. And it's been shown that these patients who have low distensibility plateau are more likely to experience food impactions. But also visually, it could help us identify subtle strictures. Here is where the LES is, and here you could see that at 14 millimeters, there is a subtle stricture. So putting this all together, if there's symptoms of eosinophilia, we recommend an endoscopy. If there's a stricture, you can dilate using a conservative approach. If the diagnosis of EOE is confirmed, then really any of these treatments are reasonable first-line therapies. And this is going to require discussion within the patient, and preferences is important. But the idea is that you could try one, and if one doesn't work, then you try the other. And if there is histologic remission, but there's still dysphagia, then we recommend assessing for the possibility of a subtle stricture or dysmotility. If there is no dysphagia, then one could consider the pros and cons of maintenance therapy. And if neither of these work, then looking for other causes or consideration of biologics. And to assess the efficacy of therapy and also to tailor the dietary therapy, we have to do lots of endoscopies. So there is a thrust to try to develop less invasive ways to interrogate the esophagus. And something that's under investigation is using the Cytosponge, which has been FDA approved for screening for esophageal cancer in patients with Barrett's. And here, it's a sponge that's compressed in a capsule, attached to a string. The patient swallows it. Then the sponge gets released, and we pull it out. Not the most pleasant, but it brings with it enough of the esophageal lining that a tissue block could be made, and it correlates very well with biopsy. So A and C here are Cytosponge compared to biopsy. There's other less invasive tests that are also under development. So clearly we've learned a lot, but there's still a lot of knowledge gaps, and especially with regard to how do we use these different treatments in combination. How do we identify patients who would benefit from maintenance therapy, and what the impact of these nutritional therapies is, as well as trying to develop non-invasive biomarkers to look at disease activity. And in terms of take-home, so EoE is a clinical pathologic disease. It's a Th2-driven disease. PPI non-response is no longer a diagnostic criterion. PPI, topical steroids, diets are effective therapies, and shared decision-making is necessary to identify what the best fit is for the patient. And it's safe to dilate strictures with a conservative approach, and Endoflip can help guide therapy. And lastly, novel therapies and new diagnostic modalities are en route. Thank you so much.
I guess I'll start. So fabulous talk, and thank you. It's something I'm interested in. It was a really nicely put together thing. I'm sort of intrigued by the scoping to assess response issue. You know, and I suppose there's some parallel in IBD when we're looking for mucosal healing and treating to that. And I'm curious what happens at Stanford. In the private world, I'll tell you, nobody wants to be rescoped. They just don't, right? They want to feel better. That's all they want. And most of them go into PPI. Most of them feel better. And most of them are uninterested, even if offered, look, I can show you your EOs go down. Like, I'm eating fine.
Yeah.
Is that, so do you guys do that? Is that programmatic in your world?
Not really. It really is a case by case, and that's a knowledge gap, right? How often should we be doing these scopes? I think while I am optimizing the therapy, then I tend to repeat an endoscopy just to make sure, especially if someone started with 150 EOs per high power field. And I may repeat the endoscopy more in those patients with fibrostenotic disease because I tend to be aggressive about dilating. But once they're doing fine, we follow, and it really is case by case as how often to do an endoscopy. So.
Thanks.
Nielsen, that was a great talk. Quick question, could you tell us a little bit more about the IgG4 story? Is this considered another organ, or is this just a unique and coincidental entity?
No, it's thought to be one of the primary mechanisms, and it's under intense investigation. And some of the newer allergy tests are actually using IgG4 specific antibody tests to try to identify foods that are culprit. But this is something that is in being intensely investigated. It's not thought to be, IgE is not thought to be as prominent as we thought. And I think, so there's a question about, whether repeated EGDs should be done as part of management. I think we addressed that. And there is a question also about EoE in infants who have not had any exposure to food antigen? Is it possible that may be transferred of antigen from mother? I don't think there's any data on that I'm aware of. Okay, thank you.